Thank you again.
Well, good evening, everyone. This is Nader Noorian. Actually, I think I've lost Chelsea here. Can you see me, Chelsea?
Yes, I can see you.
Oh, you can see me. That's perfect. Perfect. So my name is Nader Noorian. I'm an internist, board certified in internal medicine, and I've been practicing geriatrics in Mission Viejo now for the last 28 years. Sounds like a long time, and it is a long time. Some of the names that I see here are familiar to me. Welcome. Some of the names that I don't recognize, you are welcome as well. I'm very happy that people could get together. I know it's a tough time of the day. People are probably tired from work, or they got other duties, but I'll try to make this worthwhile, and at the same time I'll try to summarize things and not make things too difficult. The topic, this is going to be actually one of the many topics that we're going to talk about. I'm trying to put more of the primary care or internal medicine topics, things that would interest you. Of course, we're not going to talk about those subjects tonight. Tonight's mainly about hypertension, but along the way, if you have any questions, feel free to write it down, and we'll get to it at the end of the meeting, and I'll promise to go over all the questions that you have. Hypertension, it's a pretty common topic. As you know, incidence of hypertension is about 45% of adult population. So if you think about that, for a population of the United States, we're talking about almost 100 million people have hypertension. Hypertension is really defined by blood pressure greater than 140 systolic and greater than 90 diastolic. Now, you may have heard different numbers here and there, and I will try to explain that. Every academy of sciences got their own little definition of hypertension, but what I'm going to try to pass on to you is going to be hypertension based on American College of Cardiology, and some with American College of Endocrinology, and also hypertension. But in general, think about hypertension 140/90 or higher, or if you're taking, of course, hypertensive medication, then you're defined as having hypertension. Hypertension is got, actually, majority of a hypertension is called essential or primary hypertension. That's about 95% of the hypertension out there. Idiopathic means we don't know the cause. We don't know what happened, but people develop high blood pressure. And at the end of the day, you have to control the blood pressure anyways. 5% of the hypertension falls into the secondary category. Secondary means that there are underlying cause, and most often we have to look for that, okay? And so part of the workup of your physician through ordering blood work, ultrasound, CT scans, or other thing would be try to find out if there is a source or reason for hypertension. And of course, if you can treat the underlying reason, the hypertension will go away. This is actually a quick summary of the secondary hypertension causes. I'll go through this in a different slide in more detail. But there are the renal causes, which is related to kidney. There's the endocrine causes that have to do with the hormone production. And of course, a couple more. I think we have a better slide than this one. Let's talk about the classification. So the way that the physicians classify hypertension is a normal blood pressure is considered to be less than 120/80. And I know some of you may say, well, I've never heard of that. I thought 120/80 is actually a normal value, but no. 120/80 is actually a pre-hypertension. Usually you want the blood pressure to be less than 120 and less than 80. Pre-hypertension is between 120 to 139 systolic and 80 to 89 diastolic. In pre-hypertension, mostly we go with lifestyle management, meaning that we control the diet, we control activity, we control the weight. We'll try to stay from medications, but in certain cases, we have to actually go in that direction, depending on other comorbid conditions. Stage 1 hypertension, which is the majority of the hypertension that we see out there, is blood pressure of 140 to 159 systolic and 90 to 99 diastolic. Okay, and that's roughly about 70% of the population as far as hypertension fall into this category. Stage 2 hypertension is over 160. Actually, stage 2 goes from 160 to 180, okay, or to 179, and 100 to about 120. And then there is another case of severe hypertension, and that severe hypertension is usually over 180 over 120. Okay, so we see that periodically, but those are the ones that usually require emergency, services, people that are seen in the emergency department. This slide basically summarizes part of what I just talked about, which is really majority of the patients fall into the stage 1 hypertension, which meaning that they do require medication to control their blood pressure. Now, there is one condition that we call isolated systolic hypertension, as you know, very common in elderly, and that means that only the systolic blood pressure is on the high side, but the diastolic is usually on the normal side. It would be something like 160 over 80 or 160 over 75. So most people come in with conditions like this, and at the same time, it needs to be treated because complications associated with isolated systolic hypertension is the same as if you have both numbers on the elevated side. But again, it's a minority of the patients. Now, who are the individuals at risk of hypertension? As you know, aging is a risk factor for hypertension. So no matter if you're a man or a woman, as your age gets higher, of course, the risk of high blood pressure gets higher. Men, of course, have higher incidence of high blood pressure, but postmenopausal women also have a higher risk. So when women lose their estrogen and progesterone, that actually is not a good thing as far as protection from hypertension. Okay, so postmenopausal develop more hypertension. Family history of cardiovascular disease is an important one. That's why we are always interested in the family history as far as mother, father, brother, and sister, mainly the first degree family members. Unfortunately, sedentary lifestyle, which has been more common in the last 2 years with the COVID, is another risk factor. Stress, either psychological stress or physical stress, also contributes to high blood pressure. Other risk factors include, of course, high cholesterol. Smoking, thankfully, we don't see as much smokers in California. But again, there is still a major risk factor associated with that. Low fruit consumption. Low fruit consumption goes to the dietary management of hypertension. Fruits and vegetables are high in potassium, calcium, and magnesium. So if you don't get enough of that in your diet, your blood pressure tends to be on the higher side. Of course, weight is a very important factor. Weight gain, obesity. Just for your information, I just run down. I think I may just go back and forth just to give you enough information because this topic is pretty broad, but I'll try to just put information in any place that I can plug it in. Obesity, as you know, for us is described as BMI over 35. BMI is the way we look at an individual's weight compared to their height to see if they're overweight or not. Okay, a BMI of 25 would be normal. Up to 27 is fine. BMI over 30 falls into what we call overweight category. Over 35 is the obesity, and greater than 40 is the severe obesity or morbid obesity. Let's talk about other disorders that are also very important. There are coexisting disorders such as diabetes, which is a major risk factor for with coronary disease, and hyperlipidemia. So patients with those two conditions also have higher incidence of hypertension and alcohol intake. So everybody talks about alcohol. So how much alcohol are we talking about? So for men, more than 2 glasses of wine or hard liquor per day, or 2 beers a day. For women, more than 1 per day. Okay, so that's considered enough to increase your blood pressure. This is a little complicated, but I just wanted to have this slide here, is that in the younger patients, you can see that the blood pressure, which is actually the product of the cardiac output multiplied by total peripheral resistance. So basically, your blood pressure is a combination of those two things. It's how much your heart is pumping and what is the resistance inside your blood vessels, okay? That's how the blood pressure is determined. And you can see that in the elderly, one of the factors that's different is that the total peripheral resistance, the vascular resistance, is much higher, okay? And that's one of the contributing factors for management of blood pressure in the elderly. That's going to be different than management in a younger population, okay? We'll go into that in a little more detail down the slides. So let's talk about a couple of things. These are not, again, very common, but I like to just mention that. Secondary hypertension, which is basically hypertension with an underlying disease. In cases of kidneys, it's usually associated with renal artery stenosis. Renal artery stenosis basically means that the blood vessels that are going into the kidneys have some degree of stenosis or narrowing. That means the kidneys don't experience high blood pressure or high pressure. In that case, the kidney says, well, there's not enough pressure, so it starts producing enough chemicals to raise the blood pressure in the whole body. So that's one of those conditions that usually we rule out by doing an ultrasound, and that's called an arterial ultrasound of the renal arteries. And we see this probably a handful of times a year. We always look for it. Not very common, but once you get rid of the renal artery stenosis, the hypertension goes away. So there is no need for medical therapy. The endocrine causes that we always look for, cases where aldosterone, which is one of the hormones that comes from your adrenal gland and is in charge of increasing the blood pressure in the body, it could be on the higher side. Cases of Cushing syndrome. Cushing syndrome has to do with high production of prednisone in the body. And cases of pheochromocytoma, you probably see maybe one case of pheochromocytoma a year among maybe 10 internists. It's not very common, but that's associated with tumors that produce more adrenaline in the system. Okay, other cases, very uncommon stuff, but can be increased production of growth hormone in cases of acromegaly. People that use hormone therapy, either women that are on contraceptive or men that are using any type of anabolic steroids. And of course, patients that are on chronic steroid therapy, people that take prednisone for autoimmune or other rheumatological disease. This is actually a mistypo. This is a hyperthyroidism, okay? And hyperparathyroidism. Hyperparathyroidism causes increased calcium in the bloodstream, and that can cause hypertension. And hyperparathyroidism, of course, increases the thyroid production in the body. All right, there are a couple of other reasons, again, not very common, at least not among our population. Coarctation of aorta, which is a genetic condition that people are born with. This is usually seen early on, maybe in the pediatrics office more than in an internal medicine. By the time the patients kind of get to us, they've already been diagnosed with that. Pregnancy-induced hypertension, well, we don't see a lot of that. Mostly obese see that, and they are very good about managing that. They don't usually require our expertise on that. One of the conditions that is becoming more and more diagnosed and more common is the sleep apnea syndrome or sleep apnea. As you know, sleep apnea is a little bit different than snoring. Snoring, as you know, is just vibration of the upper palate or what we call the soft palate and the upper respiratory tract during sleep. But people that snore also have sleep apnea. Sleep apnea is periods of apnea. That means people stop breathing. And if you stop breathing more than 20 seconds, that's usually causes or at least increases the risk of having sleep apnea. And of course, that's got treatment of its own, which is CPAP or BiPAP, and we can talk about that during the different session. So why to treat hypertension? Everybody wonders about that, and I'm sure you all know about it. It's very basic. Hypertension is the cause of all these complications that you see, okay? First thing about hypertension, our blood vessels are made for a pressure of about 120/8, okay? Just like any other pipe, when you put pressure through it, if you increase the pressure, it can damage the lining of the pipe, okay? Same thing can happen in the body. So if you increase the pressure in the blood vessels, it can damage the lining of the blood vessel, which we call the endothelial layer. It's a one-layer lining inside the blood vessel. As that gets damaged, your body tries to repair that. The way that it gets repaired is by your body producing and distributing more cholesterol in that area. Think about cholesterol as maybe a putty that's trying to fix a cracked wall. So as you see more of a bigger crack, the body is going to put more putty in there, okay, and try to actually fix it. Over time, that cholesterol deposit is going to calcify, and that turns into what we call atherosclerosis, okay? And the more calcification you develop, the more obstruction you're going to cause inside the pipe, in this case, the blood vessel. So, so part of the complication that you see is related to that. Part of the complication is also related to the high blood pressure itself. For example, cases of heart failure in most cases starts with what we call left ventricular hypertrophy. That means the heart has to pump against the high pressure. So over time, the heart muscle tries to compensate against that high blood pressure by getting thicker, just like a muscle that you would exercise. As you exercise the muscle more, the muscle is going to get larger. So a large muscle is good to a certain point. When the muscle gets a little bit too large, too thick, too stiff, it actually affects the function of that muscle. So for example, the example that I talk to my patients about is Arnold Schwarzenegger, not today, but 30 years ago. If you looked at him, of course, he had very large muscles. So these people have very large muscles, but they're not very good runners. So they can't run because their muscles are too big, too stiff. So if you put him against a 14-year-old to run, he's not going to run as fast. He's powerful, but he can't run as fast. Same thing happens with the heart muscle. As the muscle hypertrophies, then he can't pump well. And that's what we call diastolic dysfunction or systolic dysfunction. And we can talk about that down the road. But again, cardiovascular complications, a coronary disease, myocardial infarct, which is heart attack, left ventricular hypertrophy, heart failure, hypertensive encephalopathy. So when the pressure goes up to the brain too much, or your brain actually shuts down. It's got its own thermostat to protect itself. So it starts shutting down the pressure, and it actually decreases the blood flow in the brain. Cerebral hemorrhage, which is a complication of hemorrhagic stroke, preeclampsia, which is a condition that we see in pregnancy, of course, stroke. You're talking about chronic renal failure. Remember, kidneys are made of blood vessels. Each kidney has about 1 million nephrons. Nephron is the unit that filters the blood. So each kidney has 1 million, and those are all made from what we call capillaries. Capillaries are the smallest of blood vessels in any organ. And those are very sensitive to damage because of a high blood pressure. So as you can see, we're always checking the kidneys and the kidney function in different ways by checking the urine, checking the blood, making sure that the kidneys are, strong enough to go through life when people have hypertension. Another thing is aortic aneurysm, which is ballooning of the aorta or other blood vessels all throughout the body in the chest and the abdomen. And for most patients, that becomes more of a screening thing, meaning that we have to do screening test to rule out aortic aneurysm. And of course, gangrene, which is the complication of peripheral vascular disease, which means basically more of a medium-sized arteries rather than the large-sized arteries. Blindness is, of course, has to do a lot with the retina, which is again full of capillaries and is very subject to damage from high blood pressure. So again, these are again the target organ damage that we look at: the heart, left ventricular hypertrophy, the brain, of course, the stroke, TIAs, and then kidney disease, peripheral vascular disease, retinopathy. So very important aspects, very important things. Blood pressure is an independent risk factor for cardiovascular disease. Okay, regardless of the other risk factors, diabetes, family history, high cholesterol, smoking, obesity, lack of activity, everything else, blood pressure by itself has a direct relationship to cardiovascular disease. Prehypertension is the phase that we really need to pay attention, because even though the amount of damage is not substantial, but it is kind of giving us kind of a heads up about what's coming as far as the hypertension. So we need to be very aggressive as far as the prehypertension is concerned. So diagnosis, clinical diagnosis of hypertension, as far as symptoms, is not very helpful. Actually, majority of high blood pressure patients don't have any symptoms. So that's why we call it the silent killer. Some would present with some typical symptoms, such as headaches, occipital headaches, morning headaches. Some can have dizzy spells. Some can have fatigue. In cases where you have, very severe hypertension, you can have epistaxis, which is basically nosebleed, blurred vision, and so on. But again, majority of the cases, especially on a stage 1 hypertension, we do not see many symptoms. All right. So how do we, again, as we talked about, the diagnosis is not that difficult. Again, blood pressure monitoring at home, blood pressure monitoring in the office, two independent days that you would have blood pressure over 140 over 90 can give you the diagnosis of hypertension. So if my blood pressure was high, about 150 over 85, or I'm sorry, in cases of, let's make it easy, 150 over 95, okay, and then on another time, maybe 3 months later, and it's 160 over 90, that's enough to put you in the category of hypertension, okay? Before that, we would just call it high blood pressure. And of course, as far as the terminology may be a little different, but the attention would be the same. Maybe it would be a little different as far as therapy. It would be maybe lifestyle management in one way versus medical therapy on the other. So for our patients that are diagnosed with hypertension, it is very important for them to monitor their own blood pressure at home. It will give you a couple of good points. First of all, it does give you a good feedback on what your blood pressure is, okay? A lot of blood pressure readings are different in the office than they are at home. A lot of patients come in and they got what we call the white coat syndrome, which is basically anxiety or stress that causes the blood pressure to be high when they are in the office, while when they go home, the blood pressure is in the normal range. So important to check that at home. Also, when you have good understanding and follow-up of your blood pressure, it does improve your adherence and compliance with medical therapy or otherwise. In general, if your blood pressure readings at home are above 135 over 85 or greater, very likely you're hypertensive to begin with, okay? And always remember to check your device in the office with your physician. We check our devices every month. We calibrate the office blood pressure machines every month. And it would be good for you to bring your machine in and to calibrate that, or at least check it against ours just to make sure you're getting proper reading. The other thing is, for a lot of these new electronic devices, make sure you check the batteries and change the batteries regularly. Regularly means don't let the battery just run down. Usually if you lose 50% of the battery, the sensitivity of the machine goes down significantly. and you may be getting numbers that may not be quite accurate. Okay, so some basic stuff, and I'm sure all of you know about this, but would be worthwhile going through. Patients should be in a seated position for at least 5 minutes, feet on the ground and arm at the level of the heart. Okay, appropriate sized cuff, and mostly what you're buying out there is adult cuff. Adult cuff means that the cuff, actually the bladder aspect of the cuff, the bladder aspect is the part that fills up with air, should be at least 80% of your arm. Okay, if it covers 80% of your arm, it's adequate for you to get proper reading, and you should get at least 2 measurements. Okay, 2 measurements would give you much better accuracy. So what are the 2 numbers that you look at? So if you ever want to check your own reading with a traditional machine, of course, it would be the first point is your systolic. Systolic, think about it as when your heart is contracting, and diastolic, think about that as your heart is relaxing. So it's not actually exactly the relaxation, which is the diastolic pressure. Diastolic pressure is actually the peripheral vascular resistance, but for sake of simplicity, it would be contraction of the heart and relaxation of the heart. All right, there is other ways of monitoring the blood pressure for patients that are, they have what we call labile blood pressure. That means the blood pressure fluctuates a lot. And we are not quite sure what these numbers are. Are they elevated all the times or not? We have the ambulatory blood pressure monitoring. So this is a blood pressure, automatic blood pressure cuff that we actually put on the patient's arm. It stays on the arm for days. It can stay there for 24 hours, 48 hours, 72 hours, and it checks your blood pressure day and night every 30 minutes. So not a lot of compliance with this, but it would be helpful for cases where we need to get more information. Okay. Of course, with more readings, we're going to have much better correlation with what we are actually measuring. And of course, it gives us a better way of prognosis. So a couple of questions, and this may be a little bit beyond what you want to know, but laboratory studies that we do, first thing that we do, we always check an EKG, and everybody questions, why do you need an EKG? We always look for that left ventricular hypertrophy, so enlargement of the heart. So if the enlargement of the heart is present on your EKG, that means that individual has had kind of a long-standing high blood pressure. Urinalysis gives us a lot of information about how the kidneys are functioning. Most often, if we see presence of protein in the urine, that means that there is some damage to the capillaries or some kidney disease that's already happening. Blood sugar, of course, you know, that's for presence of diabetes, which is an independent risk factor for coronary or vascular disease. Serum potassium, creatinine, and also measuring the GFR. For some of you, actually, I will be talking about how to interpret your laboratory studies, probably on a different talk. I think that would be very important, especially that now a lot of you have access to your laboratory studies through the laboratory or through Providence. It would be good to know exactly what these values are and how they, you know, correspond to your health. Serum potassium, creatinine. Creatinine is the way that we look at your kidney function. It's the traditional way of looking at it. Creatinine is actually a waste product that your body produces, and your body wants to get rid of it constantly. So when we see a low creatinine, it's a good thing because it's a waste product. So we want low level of that in the body. When we see a high creatinine, that's a bad thing. That means your kidneys are not working. So normal creatinine level is about 1.6 or lower in a man, 1.5 or lower than in a woman. So, but mostly, if you look at the most creatinines, they're probably 0.8, 0.9, 1.1, 1.2. Another way of looking at your kidney function, and again, just a little bit more information, is GFR. GFR is the measure of, it's the amount of blood that gets filtered by your kidney every minute. Okay, it's glomerular filtration rate. So that means the more your kidneys filter in 1 minute, the better your kidney function. Okay. And again, I don't want to go too much into that because that's going to be a different talk. And of course, calcium. These are important things to consider. Lipid profile, which is very important, usually after a fasting period of about 9 hours. We look at 4 components. We look at your total cholesterol. We look at your high density cholesterol, low density cholesterol, and also triglycerides. Looking at the urinary albumin excretion, very important. Albumin is a protein, is a very important factor for your body. Once we lose that, that means the filters in the kidneys are not working. So, and of course, there are other factors, but these are the main ones. Mostly for secondary hypertension, there is a whole panel of other things that we check, but again, you have to be suspecting that somebody has secondary hypertension. Let's talk a little bit about treatment. So lifestyle modification, very important. As you know, the first thing we ask people to do is reduce the salt in their diet. So salt should be less than 2 grams per day, 2,000 milligrams per day. 2,000 milligrams is about a teaspoon, okay? Now, how you measure that? You just basically look at the salt content of your food. And lifestyle modification, very important. Again, and first thing is weight loss. We want to keep your weight about BMI of 25. So if there is a need for weight loss, that would be very effective. Exercise, about 30 minutes of exercise, aerobic exercise per day. It doesn't have to be weightlifting. Aerobic exercise means walking, jogging, swimming, whatever you want to do, 30 minutes per day or 45 minutes every other day. That's the minimum. Of course, beyond that, we're going to pharmacological therapy. We're going to talk about that in just a minute. The goals of therapy, as you know, we're going to reduce the cardiac and vascular morbidity, mortality, okay? And our goal is to reduce the blood pressure to less than 140/90 for general populations. For patients that have other risk factors, such as diabetes, chronic kidney disease, their goal of therapy should be less than 130/80, okay? So when we see other risk factors, so patients would say, oh, my so-and-so friend said that it's 140/90 for their blood pressure, but you're telling me it's 130/80. It's because of other risk factors that the patient may have. So again, we are looking at some of the non-pharmacological treatment, a DASH diet. A DASH diet is basically a dietary approach to stop hypertension, which basically means a high calcium, high magnesium, high potassium diet. And now, you do not take potassium supplement. You do not want to take potassium supplement because potassium is a very, very critical chemical in the body. We do not want to manipulate that by taking supplements, but we want to manipulate that by taking foods that are high in potassium. Okay, quite different, quite different. So again, vegetables and fruits have a lot of potassium, magnesium, and calcium, and they will actually lower the blood pressure. Regular exercise, we talked about. Weight loss, we talked about. Reduce salt, we talked about. And of course, smoking and alcohol, we talked about those as well. Let's go to probably the stuff that's you're a little bit more interested in. This is actually a pretty good slide. So it gives you a pretty good idea of what type of response you're going to get from each of these factors. So weight reduction, if you lose about 10 kilograms, roughly 20 pounds, okay, you can reduce your blood pressure up to 20 millimeters of mercury, up to. So it could be anywhere between 5 to 20, but that's pretty good. 20 for 20. So 20 pounds for 20 points. So that's very good. If you adopt a DASH diet, which is basically a high protein, low fat, high vegetable, high fruit diet, you can reduce your pressure by about 8 to 14 points, okay? If you're talking about physical activity, about 4 to 10 points, that's pretty good. Moderate alcohol consumption, 2 to 4 points. So not everybody can do everything, but if you think about it, if you're running 150/95 and you lose 10 to 20 pounds and you start exercising, you may be able to get to goal without any medical therapy. All right, and this is a kind of a complicated slide, and I didn't want to put this in here, but it just gives you the different types of medications that we have to be able to reduce your blood pressure. Some of these are actually older medications, and we still use some of these older medications, such as clonidine. You probably have heard of clonidine. Clonidine is a central acting agent. It works in the brain to reduce the adrenaline in your system. So lower adrenaline level, and it causes a little bit lower blood pressure. Some of these medications we don't use because the side effects are too much. These are older drugs. Beta blockers, probably you know someone or maybe one of you takes the beta blocker, the atenolol, the metoprolol, and propranolol. These are actually very, very common medications. And we have the angiotensin receptor blockers. I'm going to talk to you about those. We have the alpha blockers. We got the vascular smooth muscle. So let me kind of summarize this in a quick way. The way that you can lower the blood pressure is probably three main ways. Number one, if you reduce the heart rate, you can actually lower the blood pressure. So if your heart rate comes down from 70 to 50, your blood pressure is going to come down. That's what beta blockers do. Okay. If you decrease the volume of the blood, okay, and your blood pressure comes down. You have less blood, your blood pressure is going to be lower. That's what a diuretic does. Okay. If you counteract the effect of certain chemicals in the body that cause vasoconstriction. Vasoconstriction means constriction of the blood vessels. There's those medication. If you counteract the effect, of course, you're going to get vasodilation, the blood pressure comes down. So those are the three main categories that I'm going to talk about. So let's forget about this complicated slide. But, and I'm going to go through these in general, but these are some of the ones that we use commonly. Diuretics, the most common diuretic we use is called hydrochlorothiazide. It's a very gentle diuretic. At the lower doses, it doesn't cause much diuresis, but enough to actually lower the blood pressure. Okay, so 12.5 milligram to 25 milligram is the standard dose. Beta blockers such as atenolol or metoprolol or bisoprolol or carvedilol, anything with the OL is a beta blocker. Okay, those are anywhere between 25 to 100 milligrams a day. And again, what they do is they reduce the heart rate. So when you reduce the heart rate, you're bringing down the blood pressure. Calcium channel blockers are vasodilators. They basically open up the blood vessel. Probably the most common blood pressure medication in the world is amlodipine or Norvasc. 45% of the population in the world take amlodipine. 2.5 to 5 milligram a day is the common dose. We can go up to about 10 milligram a day. 10 milligram will cause probably swelling in the legs. So a lot of people don't take the higher dose of that medication. Alpha blockers, very common in men. It takes care of the blood pressure and also takes care of the enlarged prostate. So the terazosin or prazosin, anything with OSIN, these are the alpha blockers. So this is what we use in men a lot. ACE inhibitors, very common medications such as ramipril, lisinopril, captopril. These are medications that reduce the angiotensin II, which is basically a drug that causes vasoconstriction. So less of that drug causes vasodilation. And some of the other ones is the ARBs, angiotensin receptor blockers, such as losartan. Probably some of you are on losartan or olmesartan or valsartan. These are actually some of the newest ones that we have that are actually very, very effective. Let me go through these in a quick way. I know it may be a little too much information for you, and I apologize, but it may be interesting to some people. Hydrochlorothiazide, as I said, it is one of the diuretics. The other one that is commonly used is chlorthalidone. That's another one that we use for same category. So it decreases the blood flow and the cardiac output. Let's talk about the main side effects. So it causes low potassium in individuals. It can cause low sodium. That's why we have to check the blood test frequently. It can cause your lipid panel to get worse. It actually raises your total cholesterol. It can make the uric acid levels higher. So we have to be very careful in patients that have gout. And it can make diabetes worse. So in patients that have diabetes, if they go on hydrochlorothiazide, their blood sugars do go up. Okay, so these are some of the things we have to watch with the diuretics. On the beta blockers, as you know, there is a limit to what we can do. We don't want to push the heart rate below 50 because if you go below 50, most people start getting hypotensive and they can get dizzy or they can pass out. So in that case, again, the most common side effect, I'll go through the side effect of these drugs, which is something that you may be interested in. Lethargy in men, unfortunately, impotency is going to be an important factor with beta blockers. That's why a lot of men don't like to take beta blockers. Bradycardia, slow heart rate, and of course, it can cause bronchospasm in people that have asthma, and it can make the blood sugars worse. Okay, so unfortunately, these do have some bad side effects on other components, but they're still effective drugs. Amlodipine, very popular drug, or the class overall, very popular. The other drugs in that class is diltiazem and verapamil that are used less frequently. This is actually a drug of choice in elderly because the side effects is almost nothing, unless you really push the drug to the higher levels. Okay, so headache, basically when you vasodilate in the body, in the legs, you get swelling in the legs. In the head, you can get headache. In the body, you get vasodilation, you get low blood pressure. Sorry, I'm going through these too fast, a little fast, just to make sure we make it to the end. ACE inhibitors, some of the best medications we have. ACE inhibitors, what they do is they reduce the amount of angiotensin in the body. Angiotensin is a drug that causes vasoconstriction. So once you lower the amount of angiotensin, then of course you're going to do very well as far as controlling the blood pressure. The side effect of this class is about dry cough. So some people that have a kind of a prolonged chronic dry cough, hacky cough, usually I got to clear my throat type of thing every time. That's a typical side effect we see. It's about 1% of the population that would get that. Hypertension, of course, very common in some people, and angioedema, which is a special rash. We only see that probably once in a year in individuals if you see it, but you would see that immediately after taking the medication. So very, very good class, and very effective in people that have diabetes and also in heart failure because it reduces the risk of diabetic complications. It protects the kidneys against the effect of hypertension. So good medication in patients that have high blood pressure and diabetes. The new class of ACE inhibitor is called the angiotensin receptor blockers. These are called ARBs. ARBs is basically the new improved way of reducing the angiotensin. And angiotensin, again, the drug that causes vasoconstriction. These drugs have very, very little side effects. So what is that drug? Losartan, the brother of this drug, valsartan, and then the other drug, olmesartan. These are probably most popular drugs we use for blood pressure. Again, very safe and very mild, very safe, and side effect profile very, very, very mild. Beta blockers, alpha blockers, we talked about, again, vasodilation. The bad thing about this class of drug, even though we use it a lot in men, it causes postural hypertension. Postural hypertension means that when you stand up, you can get dizzy. It drops your blood pressure. So a lot of people can actually get dizzy and they can pass out. The one that is in this class that's very popular is Flomax. Most men probably recognize that name. But again, at the same time, Flomax is a little bit more specific to the prostate, causes less of blood pressure fluctuation, but at the same time, in the same family. Okay, so this is actually a summary of all that. I think you guys don't want to get so much in detail. This is kind of a little summary of what I talked about. So the quick slide here, and I don't want to go too far into it. I just want to tell you two things. So once you start lifestyle modification, if you're not at goal would be below 140/90 or less than 130/80 if you have diabetes or chronic kidney disease. Then we would go with medical therapy. In a stage 1 hypertension, usually we would start with one medicine. Stage 2 hypertension, you need to be on 2 medications because one medicine doesn't do it. And again, there is a change in the way that we practice medicine in the last maybe 10 years. Initially, many years ago, we would start one medicine and we would maximize that medication before we would go up to the second medicine. We don't do that anymore. The reason is that once you go to the higher dose of a medicine, you're going to experience more of the side effect. So instead of maximizing these medication at their full level, we usually use lower doses of multiple medication at the same time. So we don't need to maximize the amlodipine at 10 milligram before we go to the next medicine. We'll keep the amlodipine at 5 milligram, and then we'll introduce losartan. And we won't go losartan to the full dose. We'll stay at 50 milligram instead of 100. We'll add the third drug. Because if you use multiple drugs at lower doses, you will almost get no side effect, which really affects the compliance of the patients with these medications, okay? So much better to take multiple drugs at lower doses than taking 1 or 2 drugs at the maximum dose. And this is becoming actually a little bit of a point of discussion with the patients, is trying to explain that, because nobody wants to take multiple medications if they don't need to. All right, so a little too much information here. Again, this is a summary of what we talked about. Just for most of you guys, this is important. Calcium channel blockers, again, amlodipine, diltiazem, lower extremity edema, always look for that. It's quite reversible, but it doesn't go away with diuretic. This type of edema is not fluid retention, it's a vasodilation. So if somebody comes in on amlodipine 10 milligram a day and I will put them on a diuretic, they're not going to see a significant improvement because we have to lower the dose of amlodipine to a point that we don't experience the side effect. Okay, so other than that is mainly dizziness, headache, and cough. This has to do with pregnancy. We don't worry about. In patients with coronary disease, so people that have coronary disease, bypass, stents, a beta blocker is a must, okay? And they have to be on a beta blocker. It's actually a recommendation that, that has to be followed because it does increase the survival and decreases the morbidity and mortality, people that have heart disease. So in addition to controlling the blood pressure, you always want to make sure they're on beta blocker, on the atenolol, metoprolol, bisoprolol, carvedilol, whatever choice of the physician is. They're also recommended to have an ACE or an ARB on board, a Lotensin or losartan or valsartan. Those are going to be the same thing. Congestive heart failure, in addition to controlling the blood pressure, also an ACE and a beta blocker are also a must. They have to have these things. Okay, so when you go to your cardiologist, they're not just picking drugs randomly. There's definitely a reason beyond that. Couple of things on resistant hypertension. These are patients that are on 5, 6, 7, 8 medications, and they still have poor control of their blood pressure. There are definitely many reasons. Maybe their diet is not optimal as far as salt or other aspects. Maybe they have inadequate therapy as far as the diuretic. Nobody likes to take diuretic because they urinate too much, particularly men with large prostates. Medication, probably inadequate dosing. Poor interaction between other drugs such as NSAIDs. NSAIDs are anti-inflammatories, and blood anti-inflammatories actually raise your blood pressure. The Celebrex, the meloxicam, the Advil, the Aleve, the ibuprofens, anything that you're taking as an anti-inflammatory also increases the blood pressure. Birth control pills, hormone therapy, testosterone therapy, any one of those can also do that. There are a lot of over-the-counter medications that have a stimulant effect in the body. So those need to be addressed. So that can also cause problem with the blood pressure. Excess alcohol intake, again, more than 2 glasses of wine or hard liquor or 2 beers per day can increase the blood pressure. Oh, we almost got to the end. Well, that's good. So again, hypertension, it's a major risk factor for cardiovascular disease. It increases the morbidity, mortality significantly. It is a very common condition. Actually, majority of the hypertension, unfortunately, is not diagnosed properly. Actually, a lot of people have not been diagnosed. They probably have a lot of borderline hypertension that should be treated either by lifestyle or medication, but they have not been. The latest studies that we had, I think, said that about 35% of the population is managed by hypertension adequately, 35%. So we have 65% that is not adequately controlled. Okay, hypertension is very easy to diagnose. You can diagnose it, we can diagnose it, but it also needs to be treated. Okay, and the aim of the therapy is to save the target organ. In this case, cardiovascular complications, brain, kidney, eyes. Those are the organs that get significantly affected by it. And of course, remember that lifestyle modification works. It really works. As I showed you on one of the slides, you can get significant amount of blood pressure reduction just by diet, by exercise, and most important, by weight loss. Okay, so as much as you can, try to maximize that, and hopefully that will get you to goal. I'll try not to make this past. Oh, wow, we're 8 minutes ahead. I like it.
Thank you, Dr. Noorian.
Oh, absolutely. Absolutely. Thank you. And if there's any questions, please go ahead.